Good evening, everybody. Uh, Today's class is revision class. I think I have taken this class in detail about a month ago. It is just I am repeating it on demand of the students, just like a revision class. So, uh, if the specimen is shown to you, you are supposed to identify the bone and then start describing the appearance, color, details about medullary cavity, cortex, periosteum, soft tissue infiltration, areas of hemorrhage, necrosis, newborn formation, destruction, and you have to decide whether the tumor is benign or malignant. And then you have to describe the microscopic, clinical, radiological pictures, investigation, and treatment if the examiner asks you accordingly. Further questions will depend upon your performance in above questions and also on the clinical cases. Please remember, I repeatedly told all the students that your result is mainly decided on the clinical cases. If you do very well in the clinical cases, the tables are not that essential. This is the slide which I added yesterday only. That examiner may ask you how you collect the specimen. So what you are supposed to do when you excise the tumor or take the biopsy, you have to send the whole tumor. That is first thing. Don't send the part of the tumor. The second is that it should be sent in a sterile container with 10% formalin, and you have to do this within 1 hour because this will preserve the cell. So do not delay it. Do not delay more than 1 hour, and it should be neatly labeled. And what investigation you to be done, it should be also written, and you should send to the appropriate pathologist as early as possible. If you can't send earlier, then you can preserve the specimen till at least 24 hours. You may keep it in the fridge at 2 to 10 degrees centigrade, or you may keep it in the room temperature. But it should be preserved in a 10% formalin. Then sometimes the examiner may ask you, how do you prepare the specimen? So what are the things required to prepare the specimen? One is the acrylic container with glass rod and frame, needle and cotton threads for mounting, and preserving solution. And what is this preserving solution? Is if you take 1 liter of solution, that 900 ml of water, 100 ml of 10% formalin. What is the function of formalin? It acts as a fixative agent. It also acts as a disinfectant. It preserves the tissues by stabilizing proteins and preventing both autolysis and putrefaction. Then 10 ml of glycerol also added, which prevent the desiccation, and 10 gram of salt also added, which prevents the decomposition and preserves the specimen. These things are important. Sometimes the examiner may ask you. So the first specimen comes of infection, which is very common in a country, is the chronic osteomyelitis, showing the uh, involucrum sequestrum. Here you can see the sequestrum, involucrum, and this whole thing is cloacae. Examiner may ask you about the definition, then the types of sequestrum. Uh, this is the X-ray showing the tubular sequestrum with the involucrum. Then peculiarities of sequestrum you should know. Then also the indication of sequestrectomy. This is a very interesting specimen, live specimen. This is the sequestrum, which is a dead white, irregular in margins, and it's coming out of through the tibia. The skin also shows hyperpigmentation. This is another specimen, chronic osteomyelitis of the femur. Again, the sequestrum is coming out through the femur, showing the dead white bone with irregular margins. These are the actual patients which are collected in the for OPD. This is the sequestrum which is reported. Histopathology, it shows 3 types of cells. One is the inflammatory exudate. Then second is dead bone, which shows the empty lacunae. And third is the actively resolved by the osteoclast. This is the X-ray which shows the sequestrum and periosteal neuron formation. This is the ring sequestrum, classical ring sequestrum. It is seen only at the three sides. One is the insertion of the pin or Steinman pin. Second is at the amputation stump, and third is the medullary tape of bone grafting. That is nowadays nobody does it, but previously they used to do it for the non-linear fracture phalanxes of the toes. The next specimen of mother of foot, the classical description is it shows the multiple sinuses of different stages of development. What are the stages of development? Initially, the nodule is formed, then the posture is formed, then posture is burst open to form a discharging sinus, and then slowly it heals. So you see the sinus in the different stages. Some of them are nodule, some of them are posture, some of they are discharging, some of them are healed. The skin in between is indurated, and induration is also seen in subcutaneous tissue. The skin is hyperpigmented because of it's a chronic condition. Basically, it is a soft tissue involvement, and if it is not treated early, then bones are secondary involved. This is another specimen showing the serpal granules. Then the another specimen of the foot showing the multiple discharging sinuses of classical mother of foot. Clinically, there are small hard pinless nodules. Ulceration and sinus in different stage of development are seen. First discharge, the different colors like red color, yellow, white, and black granules are seen. The skin could be scarred or there could be discoloration of the skin. The patient may complain of itching. This is how you collect the granules. These are the yellowish granules which are collected from the discharging sinus. This examiner may ask you about differential diagnosis. There are two conditions which are very common. One is a chronic osteomyelitis, pyogenic osteomyelitis, and second tuberculosis. What do you see in tuberculosis? In tuberculosis, you see the multiple sinus or ulcer with a serous discharge and undermined edges. That is how undermined edges. And sometimes you show the uh, granulomatous lesion. So typical lesion might be seen in the chronic osteomyelitis, chronic tuberculosis osteomyelitis. In chronic osteomyelitis, the diagnostic sign is the multiple sinuses with the sprouting granulation tissue. Sprouting means that indicates that there is some foreign body underneath. And in chronic osteomyelitis, I'm sure you know that chronic osteomyelitis, the foreign body is a sequestrum. So if the sprouting granulation tissue is seen, that means there is a high possibility that there could be underlying sequestrum. This is the high power view of mycetoma showing the brown granules, necrosis, and inflammatory exudate. These are the different medical treatment you can read from the textbook. And in initial stage, you should try the medicine. If patient doesn't respond, then you shall go for the surgery. And if it is only soft tissue involvement, you can do the excision of sinuses and affected tissue. If the bones are involved or joints are involved, the treatment is amputation. So even if you do the surgery, you have to give the medical treatment at the same time. This is the X-ray picture, shows the multiple osteolytic lesions. This is very typical of mother of foot. Then next specimen of the TV spine, which shows the collapse, showing the destruction of the intervertebral disc space, destruction of the vertebra, and kyphotic deformity. There are three types of kyphotic: knuckle, gibbous, round kyphosis. This is the clinical picture. When sometimes the many vertebrae are involved, then you get the collapse of the multiple vertebrae with giving it severe kyphosis. If this happens, then that there may be pressure on the spinal cord, giving rise to the various types of neurological deficit. Histopathology is classical picture. It shows the central causation necrosis surrounded by the epithelial cells. And in epithelial cells, you see the Langerhans type of giant cell. And what are the characteristics of these cells? The nuclei are situated in the peripheral margin. So these are the Langerhans type of giant cells. Radiologically, if the only two bones are paradiscal type, you see the reduced disc space and paravertebral destruction. The lesion is the central type, then it can give the concertina types of collapse. Whole body is collapsed. What are the types of lesion? You can get the classical is the paravertebral, you can get the anterior type, you can get the central type, and appendicular type of tuberculosis, depending on the lesion. You know the anatomy, how the blood supply of the two vertebra is coming up, and we know that tuberculosis infection is always secondary to some primary focus somewhere in the body, and spread is by the hematology. That's why commonest is the paradiscal type of variety. And once the cold abscess is formed, it can travel along the path of the least resistance or certain anatomical planes. Pathology you can read from the text. Management, there are three types. Initially, good old days, the treatment is only medical management. I know we have a senior faculty sitting here. Probably they must, and I have also seen patients tuberculosis early stage, late stages with complication like multiple cold abscesses or even paraplegic patient. They recovered with the bed rest and AKT. Then comes the surgical treatment, where different types of surgical procedures can be done along with the medical treatment. Dr. Tulisar, SM Tulisar, he developed the middle path regime that you should know it. What is middle path regime? Initially, you give a conservative treatment for at least a period of 6 weeks. If the patient doesn't respond, then go for the surgery. But nowadays, what is the current concept? There are two things you must do it. One is that you should have a diagnosis, histopathological diagnosis, and second is you should send the pus or tissue for the gram stain, gene stain, and gene express study, which would show you whether the tuberculous bacillar MDR type or simple type, and they will give also the sensitivity. So once you get these two things, then if the lesion is early, you can treat by just the conservative treatment, that is medical treatment, drugs and bed rest and some different types of braces. If the lesion is advanced, or then you shall have to go for the radical surgical treatment. Then next specimen of the A vein of the femoral head. This is the normal looking femur, which shows the normal articular cartilage which is intact, and also the subchondral bone which is very well vascular. This is the normal looking. But if there's a AVN, then the articular cartilage is lifted off the bone, and there could be the fracture through the necrotic segment. This is the high power view. Then the examiner may ask you different causes. These are the four important causes. There are, I think there are about 26 causes of EVN, but these four important causes you must know: idiopathic, post-traumatic, steroid, and alcohol. Then there are different types of treatment, including medical treatment and different types of surgical procedure, depending on the stage at which the patient comes. Then the next specimen is of the pigmented villonodular synovitis. This is the orthoscopic view, which shows the chocolate color mass on fibrous connective tissue with rubbery consistency. If you excise the synovium, which shows it resembles the fine spongy rubber, gray and pale yellow in color. If you take an X-ray of the lytic lesion like this, then it changes. MRI would show the effusion with the intraarticular and intraosseous masses that are dark in color, like this. This intraarticular mass, intraosseous mass. If you open the joint before the synovectomy, this is the pigmented urinaria specimen, and after doing the synovectomy, and this is the synovial membrane with the loose bodies or nodules which are removed from the joint. Histopathology, there are four types of cells. One is the synovial cell proliferation. Second is the xanthomatous cell accumulation. Third is the hemosiderin deposition. And fourth is multinucleated giant cells. Clinical picture and orthoscopic, they may ask you. Treatment is a orthoscopic synovectomy or open synovectomy. If it recurs, then radiotherapy can be given. Then comes to the bone tumor. How will you diagnose? These are the factors one we should consider while the diagnosis: age, sex, bone, location in the bone, radiological picture, and gross and microscopy. That is the whole. All these factors will give you final diagnosis of a bone tumor. I'm not going to guess. Malignant bone tumors. The first one is the osteosarcoma. This is the big, bulky, gray-white gritty tumor arising from the femur. There are areas of hemorrhage and cystic degeneration. It can spread to the cortex, medulla, epiphysis, joint space, and tissue. This is another specimen of the osteosarcoma showing the Codman's triangle. This is the osteosarcoma arising from the lower end of the femur. This is the osteosarcoma arising from the upper end of humerus, showing the infiltrative growth. Another specimen showing there is a large tumor arising from the metaphyseal region of the proximal femur. Then the cortex is breached and there is a permeation into the medullary cavity. The tumor looks fleshy, shows areas of hemorrhage and cystic degeneration. Histopathologically, it shows the pleomorphic tumor cells. The most important is the tumor osteoid. This is the tumor osteoid and tumor giant cells. This is the microscopic picture of osteosarcoma. There are three types of cells. One is the pleomorphic tumor cells with large and hyperchromatic nuclei like this. The most important is the tumor osteoid. You must see the tumor osteoid in a slide to call it as osteosarcoma. Otherwise, you cannot label that slide as osteosarcoma. So tumor osteoid, how it looks like is without intervening the uh, cartilage. Osteoid is a eosinophilic, glassy, irregular, counter with the rim of the tumor cells. And there are bizarre type of giant cells and with mitosis. This is another view of this microscopic picture, which shows the spindle cells, high grade of hypercellularity, abundant mitotic figures, marked pleomorphism, and malignant osteoid. Histological, there are three types: osteoblastic, chondroblastic, fibroblastic, depending on the which element is dominant. If it is osteoblastic, it looks like a yellowish. If it is a chondroblastic, it looks like a bluish, and if a fibroblastic, it looks white. But whatever the type may be, it should show the osteoid. Is very tumor osteoid must be seen. Then this is a radiological picture. There are these are the classical signs which are seen on these X-rays: metaphyseal destruction, soft tissue infiltration, Codman's triangle, sun ray or sunburst appearance, and ghost shadow. Uh, the tumor could be lytic or blastic. There is a cortical destruction and perostical reaction in the form of Codman's triangle or hair on end soft tissue mass. Management, you have to grade the lesion first, and then depending on the grade, you can treat it either by doing wide surgical excision or limb salvage surgery or maybe amputation. But preoperatively, you must give the neoadjuvant chemotherapy. So with this, 5-year survival rate is almost 60 to 80%. And this is the tumor arising from the lower end of the femur, which was given preoperatively chemotherapy. Then the whole tumor was excised and replaced with the prosthesis. This is the conventional osteosarcoma, which I told you last time. This is the it's a very unfortunate patient who had initially had a very small tumor of the distal femur. Uh, he went to the Tata where the biopsy was done and it was diagnosed as osteosarcoma. He received 2 cycles of preoperative chemotherapy, but because of the socioeconomic status, he came back. He could not stay in Mumbai and he wanted to go back for the further chemotherapy and surgical treatment. But because of Corona pandemic and lockdown, all the public transport were stopped. He could not go. He stayed at home and he did not receive any treatment. And as a result, the tumor has increased so much. This is the when he came to our hospital. This was the size of the tumor, which shows the dilated veins, foot drop, and a variegated consistent. At places it was hard, at places it was soft, at places it was firm. Distal pulsations were very well fed. This is the radiological picture which showing the cross destruction of the bone with soft tissue infiltration and metaphyseal, and sun-ray appearance. We did the CT sketch or CT, which showed a few micrometastasis. CT abdomen did not reveal any metastasis, so we decided to go for the disarticulation of the hip joint. This is the specimen after disarticulation through the hip joint. This is the cut section. And after the surgery, once the wound has healed, patient has gone back to the Tata now, and he has already received 2 cycles of chemotherapy. And he's just about a month ago he came, and his health is okay. This is the cut section. Actually, the tumor was so hard. We broke 2 saws while cutting this whole specimen from femur to condyle. So this is the bulky grayish white gritty hard tumor showing the Codman's triangle. There was a pathological fracture also. This is the large tumor, very large tumor. There is sundry appearance which is seen on the X-ray also. There is areas of hemorrhages and necrosis and normal epiphyseal end. This is the very classical and conventional osteosarcoma. That's why I included this for the teaching purposes. This is the histopathological view of the same patient, which shows the malignant tumor cells synthesizing the new bone. There are new plastic cells with marked atypia and tumor osteoid. The next specimen of tumor is a parosteal osteosarcoma. About 60% of the tumor arises from the lower end of the femur. The age group is not younger age group as you see in the conventional osteosarcoma. It is an older age group. It's a well-defined tumor arising from the usually the posterior surface of the distal femur. It arises from the cortex. Medullary canal is not usually involved, and soft tissue involvement is also not there. It's a low-grade tumor and slowly growing tumor. Classically, it is a lobulated ossified mass. So when you take a cut section, the mass is lobulated. Even on the MRI, it shows the lobulated mass, and on X-ray, it shows that mass arising from the posterior surface of the tumor. Histopathologically, it shows the slightly atypical spindle cells and collagen fibers with embedded normal appearing bone trabeculae. The next specimen of the Ewing sarcoma. This is the tumor arising from the usually from the diaphysis or sometimes from the metaphysis. Uh, this is the medullary canal of the metaphysis. There is a ill-defined growth involving the medulla and cortex. There are areas of hemorrhage and necrosis. This is another specimen of osteosarcoma arising from the humerus, which shows the tumor arising from the metaphyseal and diaphyseal junction of the humerus. There is extensive invasion of the medullary bone with the destruction of the endosteal and cortex, and there is a grayish white soft tissue mass with areas of hemorrhage and necrosis. Histologically, it shows the solid sheets of uniform small round blue cell. That's why it is also called as round cell sarcoma. There's a scanty neoplasm with
स्क्रीन स्क्रीन शेअर करा सर. सर
Yes, sir. Now we can see. Now we can see.
मागच्या स्लाइड्स दाखवा सर, याच्या अगोदरच्या काही स्लाइड्स बॅक साइडच्या. ठीक आहे सर, कंटिन्यू करा सर.
This is the X-ray of Ewing sarcoma showing the onion peel appearance, and the treatment is just like osteosarcoma or any malignant tumor. where you have to consider, you have to stage the disease and give the chemotherapy. These are the chemotherapy drugs, and do the limb salvage surgery if possible. 5-year survival rate with the combined aggressive treatment is about 60 to 70%. This is one of my student who is working in Ahmedabad as a ortho-onco surgeon. He sent me these slides. This is the 12 years old girl who had a Ewing sarcoma of the proximal tibia, which was in early stage, and they gave him a chemotherapy preoperatively, and then the excised the proximal tibia, and then replaced with the indigenous design joint, which has a minimally invasive mechanism of expansion also along with the growth. This is the processes. Then the next specimen is of chondrosarcoma. It's a lobulated chondroid tumor, pearly white in color, or light blue and pearly white, with focal calcification like this, and small cystic areas. This is another specimen of proximal humerus chondrosarcoma, which showing the areas of white shiny hyaline cartilage, erosion of the cortex, extension into the medulla, into the soft tissue, areas of hemorrhage, and areas of calcification. So calcification is very, very important for the chondrosarcoma. So radiologically, you should have an extent of endosteal scalloping and pattern of different types of calcification, may be indicative of high grade chondrosarcoma. Histologically, it shows anaplastic type of cartilage cells showing the different characteristic like hypercellularity, plump nuclei, binucleate cells, permeative patterns, and entrapment of bony trabeculae. And second is the pleomorphism and tumor joint cells. Radiologically, this is the chondrosarcoma arising from the proximal humerus as well as from the proximal fibula. Treatment-wise, there are two types: low-grade sarcoma, where you can do the extended curettage and adjuvant therapy. You mean high-grade chondrosarcoma, wide and radical resection, or sometimes amputation. Please remember this chondrosarcoma resistant to chemotherapy and radiotherapy. Prognosis of the tumor, 10-year survival rate for low grade is about 90%, and high grade is about 20 to 40% if the appropriate treatment is given. The next specimen is of multiple myeloma. The bones which are affected are the bones which are containing red bone marrow in elderly population, usually about 40 years. And what are those bones? This is the skull bones, ribs, vertebrae, and pelvis, because these bones, they contain the road bone marrow after the age of 40. And these multiple or solitary masses, they're gelatinous, soft, and red masses. Histologically, it shows the plasma cells, sheets of plasma cells like this. And what are the high power of plasma cells? They are small round blue cells with clock face nuclei like this, and abundant cytoplasm with perinuclear halo. And what is the most important investigation is plasma protein electrophoresis. Normally, it looks like this, just like our fist. This is the albumin, and this is alpha 2 and beta globulin, and this is the gamma globulin. In normal pattern is like this, but in multiple myeloma, the pattern is like this, and it shows the protein embankment. Radiologically, it shows the multiple osteolytic lesions, and the treatment is basically chemotherapy, steroid, then novel therapeutics, stem cell transplantation, sometimes radiotherapy, surgeries to fix the pathological fractures, or to do the spinal decompression if the patient has got neurological deficit. So whatever you do, most patients die within 3 years after the diagnosis. The next specimen of the giant cell tumor, or also called as osteoclastoma, is the epiphyseal tumor, large red-brown cystic degeneration, This is the lower end of the femur, showing the expansile lytic lesion with eggshell crackling. Radiology features this epiphyseal location and may extend into the metaphysis. It starts in one of the corner. That's why it is also called as tumor sitting in the corner. It starts in the one of the corner of the epiphyseal location, and it spreads to the opposite condyle or towards the medulla. So it's a lytic lesion, expansile with thinning of the cortex. Multiple peripheral bony regions giving rise to the subverbal appearance, and there is no terrestrial reaction. Histologically, it shows three types of cell. One is a uniform oval mononuclear cells with indistinct cell membrane. Second is osteoclast like a giant cell. How do you differentiate from Langerhans type of giant cell? In Langerhans type, the nuclei are situated in the periphery. In osteoclast type of giant cells, it's situated in the center. So this is the enlarged view of the giant cell. The number of nuclei is about 40 to 60. The foreign type of giant cells also look similar, but there the number of nuclei are more. This is another specimen of a giant cell. This is the lower end of radius. This is a clinical picture. This is a radiological picture which shows expansile tumor with thinning of the cortexes and subverbal appearance. He underwent surgery. This is the excised bone along with the tumor, which shows the expansile lesion, areas of cystic degeneration, and hemorrhagic areas. After surgery, we did the dissection and orthosis of the rib joint. This is the post-op picture. There are the different types of treatment for giant cell tumor. Bone grafting, you can excise the tumor if the bone is dispensable. Sometimes you have to go for the dissection orthosis, or in like this. The most important or commonly asked question about the denosumab drug. This is the drug which is basically is a rank L inhibitor. It limits the osteoclast maturation and inhibits the tumor-associated bone lysis. And what is the dose? Is about 120 milligram given subcutaneously on day 1, then on day 8, day 15, and day 29. And thereafter, every 4 weeks till you get a desired effect. Sometimes it is a recurrent giant cell tumor with very large tumor. One may consider amputation. Then coming to the benign tumors, is the most popular tumor. There is a osteochondroma, or also called as exostosis. Basically, it shows the cartilaginous cap, which is bluish white in color, and osseous bone stalk. This is the radiological picture. And these are the various questions that can be asked to you in the examination. And the commonest question is asked about the complications. And the treatment is mainly depend on the complication. If the patient has complication, then you treat it. Otherwise, you don't treat it. And what are the complication is pain, pathological fracture, interference with the joint movement, neurovascular stretching or compression, and sometimes malignancy. And if the complication is there, then you have to remove the tumor. This is another specimen of the osteochondroma. This is the radiological picture. This is the pedunculated type of osteochondroma. This is the intraoperative picture showing the bluish white tumor, lobulated tumor. This is the excised tumor, which shows the cartilaginous cap and as well as the osseous element. There are three classical benign bone tumors they can be asked in your examination. The one is we already discussed osteochondroma, which on cut section it shows the cartilaginous cap and osseous bone stab. This osteoderma, which shows the small central nidus surrounded by the bony sclerosis. And this is the enchondroma, which shows the nodular gray blue translated lesion. This is the microscopic picture of these three tumors. In osteochondroma, you see the cartilaginous cap, then the mature chondrocytes with endochondral ossification, then mature osteoclast and bone marrow pedicle. In osteoderma, there is a small central nidus of one bone rimmed by the single layer of osteoblast surrounded by the thick sclerotic bone. In enchondroma, you see the well circumscribed hyaline matrix, benign neoplastic chondrocytes. This is the radiological pictures. This is the osteochondroma. This is the osteoblastoma. You can see the sclerosed central area surrounded by the sclerotic bone. And this is the enchondroma or chondroma arising from the fifth metacarp curve showing the calcification. Then sometimes they may ask you how will you differentiate between these four tumors because they come as most of the time they are seen in the fingers. So in GCT, histologically they are uniform oval mononuclear cells with indistinct cell membrane, osteoclast like giant cell, and many multinuclear giant cells in the sea of mononuclear stromal cells. In endochondroma, there are lobules of hyaline cartilage encased by bone or covered by the perichondrium. There is areas of calcification, endochondral ossification, and also necrosis. In brown tumor, there is a hyperparathyroidism. You see the fibrous tissue, one bone supporting vasculature, but there is no matrix. In spina ventosa, also called as tuberculous dactylitis, where you see the caseation necrosis surrounded by the epithelial cell and Langerhans type of giant cell. These are the radiological pictures of all these four tumors. This is the GCT from the proximal end of the proximal phalanx, which shows the expansile lesion with soap bubble appearance. This is the enchondroma showing the expansile lesion with calcification. This is the brown tumor, which shows sharply defined round or oval radiolution areas. Sometimes it may appear multilocular. And this is the spina ventosa or tuberculous dactylitis, which shows the fusiform dilation of the bone with thinned out cortex and destruction of the specimen is a tumor, giant cell tumor of the tendon sheath, which is the circumscribed, lobulated, white, gray, brown, yellow, orange color hemosiderin pigment. Histologically, it shows mononuclear cells. There are also epithelial cells. Then the osteoclast type of giant cells. Then siderophages and home cells, also called as histiocytes with fibrous tissue. Then the next specimen of the aneurysmal bone cyst of proximal tibia, which shows the expansile centrally located lesion in the proximal tibia. Cortex is thinned out, which also shows the cyst, which is just like a sponge-like with multiple blood-filled cavities. This is the radiological picture. This is another specimen of the giant aneurysmal bone cyst, which looks spongy, hemorrhagic mass covered by the thin shell of reactive bone. And this is the histologically it shows the cyst and septae lined by the fibroblasts and histiocytes, and most important is the clusters of osteoclast-like multinucleated giant cells. This is the clinical picture and radiological picture of aneurysmal bone cyst. You can read the treatment from the textbook. Simple bone cyst. I don't have the specimen, but this is the clinical picture. This is the patient comes with the painful arm. X-ray shows the simple bone cyst with pathological fracture and fallen fragment sign. This patient was treated successfully with the intralesional steroid. Then next specimen was loose bodies. This is the jar containing multiple loose bodies. This is the X-ray shows multiple loose bodies. The question can be asked about the definition, types, then the clinical picture, what are the causes of loose bodies? These are the various causes, and management. If it is small, you can give a painkiller drug. If it is large, you can remove the arthroscopically. If it is very, very large, then you may have to do the orthotomy. This is this slide of showing the synovial chondromatosis. These are the multiple loose bodies with inflamed and thickened synovial membrane. This is the X-ray picture showing the multiple loose bodies. Histopathologically, it shows the synovial cells showing the metaplastic changes and chondrocytes. Then some trauma specimens which are lucky to get few patients who underwent amputation for some other reasons, and they had some fracture problems like malunion, non-union. So I dissected soft tissue and mounted that for the teaching purposes. So this is the specimen of the non-union of tibia. You can see the gap at the fracture site. And so diagnosis is very clear cut of non-union of tibia, and fibula is malunited. You can see it here. And what are the questions are likely to ask? What are the causes of non-union? What are the types of non-union? Clinical features, radiological features, and management. This is the patient who had a fracture of the proximal tibia. The fracture is united in anatomical position, which is fixed with the plate. So here the question are likely to be asked are what are the approaches to the proximal tibia? What are the different types of implants they are used for the fixation? The next specimen of the malunion of femur, distal femur, which was fixed with the T plate. Actually, this is not the proper implant. I didn't do this surgery, was done somewhere else. And this is the patella. This is the, you can see this is a malunion. This is a varus deformity. And this is the plate. And questions are likely to be asked are what are the causes of malunion, types, clinical feature, radiological features, and management of malunited fractures. This is another specimen of the distal femur, which was fixed with this was actually non-union, which was fixed with the lateral condylar plate and fibular graft. Actually, I did this surgery, but unfortunately, it went into slight malunion, and patient developed peripheral vascular disease after 10 years. Then, for which he went under amputation. So I dissected out the distal femur as well as the proximal tibia. This is the very interesting specimen. Last time I showed this, but again I am repeating it. This is the 60 years old female from a tribal area of Dhule district. Initially came to the OPD with gangrene of the toes, and the diagnosis was bit of peripheral vascular disease, and she was advised amputation. But she refused, went home. Her son was educated. She didn't listen to him also. He went to work in Mumbai. She stayed at home, and one medical quack used to come for the dressing. We actually do not know what he did. But when she came in septicemia after a few months. And this was the picture. So I thought it's very interesting. I should show it as a specimen. This is the tibia, which shows the bone which is getting sequestrated. This is the pink color bone. Probably this is alive, maybe because of the patent nutrient artery. This is the fibula, which also looks pink. And this is the white color, which is getting sequestrated. This is the slough with necrosed tissue. This is an unhealthy pale granulation tissue. And you can see the foot is totally gangrenous. Then this is what about specimen. Now I have included few slides of the microbiology because they are important for at least the candidates who are appearing for the MS examination. So they have, I don't know about the DNB candidates, but in MS examination, there are spots of 60 marks, and one of the spots could be of biology. And what they do, they put a slide of either Graham stain or Jensen stain, and you have to identify the organisms, and then you have to answer the relevant questions. So the most important, how will you collect the sample? If you want to send the, if you suspect the infection or if there's a pus, how will you send it to the lab? The most important is you have to send the fluid rather than the swab. Sometimes you can send the tissue also. And if the ulcer is there, then you have to clean the surface with the sterile saline, and then the tissue or inflammatory material from the base of the ulcer is to be collected. And this pus or fluid or the tissue is to be taken in the sterile container. It should be neatly labeled and specify what investigation to be done. And it should be sent to the lab within 15 minutes. This is very important. Sorry. So this is to be sent within 15 minutes. If it is not possible, then you can keep the specimen or sample in the fridge at 2 to 4 degrees centigrade. But if you keep outside, or if you even if you keep it in the fridge, the bacteria or which are present in that sample, they are likely to die, and then you get the report like bacilli are seen, but they are dead, and probably they are responding to the antibiotic or drug which is started. So this sort of report which is not suitable for treating orthopedic surgeons. So that's why you try to send the sample which is collected as early as possible, preferably within 15 minutes. Actually, you should ring the pathologist or microbiologist that you please stay in the lab. We are sending this sample, and you should supposed to do the gram stain, and you should tell us what are the organisms in. Then you can subject that organism for the culture sensitivity. That report comes after 2 or 3 days. This is very important. Examiner may ask you how will you collect the specimen. So the first is the Clostridia tetani. They are basically gram-positive bacilli, anaerobic, and spores are terminal, like this. That's why they are also called as tennis racket or drumstick appearance. So you may ask about the clinical pictures and treatment. So this is how we should identify this. The next is of the gas gangrene. Basically, they are gram-positive bacilli, and the spores are central or subterminal, like this. In tetanus, they are terminal, they are central or subterminal. And then you may be asked, this is very important. I mean, I don't know how many of students you have seen the case of gas gangrene. Once you, even if you see one case, you will not forget throughout your life, because the skin discoloration, skin blebs, secondary crepitation, thin watery, and very, very typical false smelling. So this is very important, and the treatment is mainly the supportive. Then gram stain, that is a gram-positive cocci. Gram-positive cocci, these are seen in the cluster. Commonest is the Staphylococcus aureus. They are darkly stained, round, occurring in bundles like grapes. Then the question may be asked about the treatment or any clinical features. This is the gram-negative bacilli, and the characteristic depend upon which type of bacilli is seen. Then the A, B or acid-base bacilli. They are basically, these are the acid-fast bacilli. These are basically, they are non-motile, non-spore forming, and non-capsulated bacilli. They are gram-positive but stained poorly. And acid fastness is due to the high lipid content of their cell wall. Then the relevant question may be asked about AKT and how do you do the gram stain or Gill-Nielsen stain. So that is how these are the states of the gram stain. I think preferably you should read it. Sometimes this may be asked in the examination, practical examination. So you should know the Gill-Nielsen staining steps and gram staining steps. And the last part is the osteology or bones. Then here again, you're supposed to identify the bone and which side it belongs. Sometimes they may ask you, how will you hold in normal anatomical position? Then you have to describe various parts of the bone and applied surgical and applied anatomy. And obviously, further questions will depend upon your performance in the above questions and clinical cases. Then just like how you prepare a specimen, sometimes they may ask you how you prepare the bone. If somebody is willing to donate his bone to the teaching purpose, then how will you do it? So you have to do the proper dissection and separate the bones. Clean the bone with the scalpel. Immerse the bone in 5% HCl for 24 hours. Then polish the bone with glycerol. Then dry in oven or sunlight for 24 to 48 hours. And then apply boric acid powder for protection from the insects. Coming to the osteology, this is the spine. I'm sure you must be knowing, just a repetition of your anatomy: 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal vertebrae. In cervical spine, there are 3 types of vertebrae. There are 2 atypical, there is C1 and C2. You can see here there is no body, and there is a foramen in the transverse process. In C2, there is a body, but there is an axis. This represents the body of the C1. And then the typical vertebra, there's a presence of the transverse foramen in the transverse process. And you can see there's a lamina, spinous process, body, all things are there. In thoracic vertebrae, the identification done by the presence of the costal facets on the lateral surface of the body as well on the transverse process. In lumbar vertebra, basically it is a large vertebra showing the body, transverse process, spinous process, superior articular facet, inferior articular facet. And there is no foramen in the transverse process, and there are no facets on the body as well as in the transverse process. So this is the table which shows how you differentiate it. In cervical spine, there is a presence of foramen in the transverse process. And what are the direction of the facets? Is a 45-degree to the transverse plane. In thoracic spine, there is a costal facets on the laterals of the vertebral body as well as on the transverse process, therefore the ribs. And what is the direction of the facet? 60-degree to the transverse plane and 20-degree to the frontal plane. In lumbar vertebrae, basically it is a large vertebrae, but there is no foramen in the transverse process, and there are no costal facets also. And what is the direction of the facet? Is a 90-degree in sagittal plane. And what are the questions are likely to ask about the curvature, movements, different movements, and then different types of deformities, and then depending on the choice of examiners, maybe traumatic injuries or tuberculosis spine or degenerative spine or scoliosis, anything. It's up to you how you lead the examiner. Then the most important thing is about the spinal surgery is about the pedicle screw insertion, because the most of the surgery, even corrective scoliotic surgery, or even if you want to fix this fracture spine, or even if you want to fix the infected lesion or degenerative lesion, this is the basic of pedicle insertion. You must know it. They will ask you certainly. So in thoracic spine, what are the entry points? Lateral border of the superior facet, lateral border of the inferior facet, reach on pars interarticularis and transverse process. The entry point is just lateral and caudal to the intersection of all these three lines. In lumbar spine, you have to identify the pars articularis mammillary process, lateral border of the superior facets, and mid transverse process. And what is the entry point? Confluence of all those four lines. Now, what are the steps? You define the entry point, open the cortex, create the pedicle tract, and direction should be craniocaudal angulation and mediolateral inclination. This is to avoid the damage to the nerves and spinal cord. Then you probe, make sure that you are in the bone and you are not outside the pedicle. Then you have to do the tapping and insert the appropriate screw of appropriate size. Then comes the scapula. It's basically a triangular flat bone which is situated on the posterior part of the body. This is the glenoid cavity. This is the coracoid process, acromion, triangular flat surface. This is the costal surface. This is the posterior surface. This is the spine of the scapula. This is the supraspinatus notch. This is the sphygmomanoid notch. And what are the important things? Surgical anatomy, suprascapular nerves and blood vessels. They are present in the suprascapular notch as well as the sphygmomanoid notch. And there are totally 18 muscles are attached to the scapula. 3 are, one is subscapularis, and then the supraspinatus here and infraspinatus here. And the rest of the other muscles are attached to the border of the scapula. In the clavicle, there are 7 picolettes of the clavicle. Important structures which are there are subclavicular and brachial plexus. And they may ask you about the fracture clavicle or acromioclavicular joint dislocation or sternoclavicular dislocation. They may ask you different types of management. The examiner is very funny. He may ask you treatment of choice of a fracture clavicle in your popular film actors, because if you treat her conservatively, she will like to have a deformity which she wouldn't like it. If you want to do the surgery, she may have a scar which looks ugly. So again, she will not like it. So we have to prepare for this answer. The different attachment of the muscular attachment to the clavicle. The next bone is the humerus, which shows the head, lesser tuberosity, greater tuberosity, shaft, anatomical neck, surgical neck. These are lower end. Medial epicondyle, lateral epicondyle, trochlea, and capital. What are the frequently asked questions? Blood supply to the head. The nerves in relation to the humerus. What is the normal retroversion? Is about 40 degrees. What are the different muscles are attached? Approaches to the shoulder joint, anatomical versus surgical neck, and then the supracondylar fractures. This is the blood supply. Is mainly from the branches of the axillary artery. This is the anterior circumflex femoral artery. This is the posterior circumflex femoral artery. There's some blood supply comes from the rotator cuff. And basically, they enter into the tuberosity, lesser tuberosity and greater tuberosity. So that's why if there's a four-part fracture, that means fracture of the neck, greater tuberosity, lesser tuberosity. If it is displaced four-part fracture, patient is likely to have a avascular necrosis. And the incidence is about 40%. Nerves in relation, there are three important nerves. Is the axillary nerve, which is present in the surgical neck, in the posteromedial aspect of the surgical neck. Then the radial nerve, which is present in the radial groove or deltoid tuberosity here, and ulnar nerve, which is present in the beside the medial epicondyle. Then these are the different muscles are attached to the head and humerus. There are various approaches, but you should know detail about the anterior or anteromedial Thompson and Hendricks approach and anterolateral limited deltoid splitting approach. This is for to fix the deltoid tuberosity or sometime to the open repair of rotator cuff tear. Then the proximal humerus fracture. This is again a popular question. You should know the Nails classification in detail, also EVO classification. The treatment again, conservative if it is not displaced, and if it is displaced fracture, then operative. These are the different types of implants are used. They may ask you about the hemiarthroplasty. There's a Nails prosthesis, then the total shoulder arthroplasty, as well as the reverse shoulder arthroplasty. Then coming to the elbow, this is another popular question on terrible triad of elbow. What is the triad? There's a dislocation of the elbow. There's a fracture of the head of radius and fracture of the coronoid process. Now, will you treat it? You have to reduce it by a closed method. Radial head should be fixed or replaced with the prosthesis, and coronoid fracture should be stabilized. And also, lateral collateral ligament should be repaired. So also posterolateral capsular repair. Medial collateral ligament, if it is injured, one can do it, but even if you don't do it, the results are good. Then the next one is the radius, shows the various parts: head, neck, radial tuberosity, interosseous border, shaft, and styloid process. What is the frequently asked question about the nerves in relation? The most important is the posterior interosseous nerve. So you must know how will you protect this nerve while doing the surgery on the proximal third of the radius. Fracture of the distal radius, various different types of implants or different types of surgical management can be asked. Allah, there are two interesting problems they can be asked in the examination. One is the coronoid process, and second is the sepsis injury. In coronoid process, they will ask you what are the different muscles. Normally, we don't read this in detail, but these are the muscles are attached: brachialis, one head of flexor digit superficialis, one head of frontal teres, flexor digitum pollicis, and flexor pollicis, as long as they are partially attached to the coronoid process. In surgical approaches, one can go from the lateral side after excision of the radial head, or sometimes from the medial side. There is a flexor carpial nares splitting approach. When coming to the wrist, the carpal bones, the most popular bone is scaphoid bone. They may ask you to describe the bone, but the commonest question is asked about the blood supply. It is a retrograde blood supply to the proximal pole has got a very poor vascularity. That's why after fracture scaphoid, avascular necrosis can occur in the proximal pole. These are the two major blood supplies from the dorsal side, that is the dorsal carpal branch of the radial artery, and 70 to 80% blood supply come from the dorsal artery. Then the polar side is about 20 to 30%, and this is the branch of the superficial palmar branch. That's why if you want to do this open surgery, you should go from the polar side, so that the blood supply from the dorsal side is preserved. And these are the different questions can be asked in your examination. Bennett's fracture, again very popular fracture. Basically the fracture dislocation of the base of the first metacarpal. And why it is unstable? Because of the attachment of these two muscles. And what is the treatment? There are different types, close reduction and percutaneous fixation. That is very popular treatment. If the reduction is not possible, then you may have to do the open reduction and fixation. Or sometimes you can put the distraction with external fixator. Then coming to the lower limb pelvis, there are two innominate bones, and each bone comprises three bones: ilium, ischium, and pubis. And posteriorly there is a sacrum. These are the different parts of the pelvis. If the pelvis is given, they may ask you how will you hold the pelvis in a normal anatomical position. Sorry, I don't have the specimen with me now, but you read it from the anatomical textbook. And then the commonest question would be on the pelvis fractures. They may ask you the classification, mechanism of injury, clinical features, investigations, treatment, that is emergency treatment, and definitive treatment. Or anything can be asked on the pelvic fracture. If the single pelvic bone is given, then the commonly asked question on the acetabulum. And how will you classify the acetabulum? There are two column concept which is developed by Jurett and Lornell, the anterior column and posterior column. So this red is the posterior column, the wall. This the white is the anterior column and anterior wall. So this is the classification, Jurett classification. This is the elementary fractures: posterior wall, posterior column, anterior column, and transverse fracture. And then there are associated fractures also. Then treatment, it is really understood. You can treat by conservative methods by putting a scale retraction for at least a period of 6 weeks. If it is operative, then you should know approaches, and the most important approach is the ilioinguinal approach and posterior approach. So they may ask you approaches on the hip joint. So there are various approaches, but you must know in detail about posterior approach, which is very commonly performed by the Indian orthopedic surgeons who are trained in India. And the direct approach, there are questions would be then femoral anteversion, fracture neck of femur, intertrochanteric fracture, AVN, and different muscle attachment. So what is the blood supply? It comes from the three sources. One is from the nutrient artery, ligamental artery, but most of the blood supply is from the capsular or retinicular vessel. The plexus is formed by the lateral circumflex and medial circumflex artery. This is the femur, which shows the fracture with interlock nail. Then the patella. Patella is again popular bone. So you see there is an anterior surface and posterior surface. There are three facets. One is the lateral facet, which is large, then the medial facet and odd facet, and this is the apex. Then they may ask you what are the functions of patella, what is the treatment of fracture patella. Sometimes they may ask you patella tracking in total knee replacement, or
Recently, a lot of interest is developed in patellofemoral instability. Sometimes they may ask how to identify the patella. So you can see the apex, upper border, and posterior surface, the large lateral facet. So that is how you identify. And the easiest way is that you identify the apex of the patella, point the apex away from you, and put it on the flat surface. So whichever side the patella lands will be the side where it is found. Then the tibia, again, if the tibia and fibula is given, you will describe the various parts of both the bones. Then you may be asked on the compartment syndrome, whether non-linear or bilinear fracture of distal tibia. Then the different fractures like tibial spine, tibial plateau. A lot of interest is recently developed in fixation of plateau. Malleolar fractures, different implants. What are the implants used? Often compression plate, small DCP, Prof plate, and it is a fixator. In fracture tibia, you can do the nail plate external fixator. Proximal tibia fracture, there are various classifications. You should know the Sasgar classification, AO classification, Holst and Woods classification, and recently city-based classification. There is a four column fractures. So depending on the which column is involved, we can approach it either anterolateral or a posteromedial or posterolateral or medial, or recently nowadays try to use the anterior midline approach, because if this patient needs totally replacement later on, that can be performed without any skin problems. The fibula, they may ask you how you identify this side. So you have to see the lower end, there's a fossa. You try to put your thumb in that fossa. So if the right sided thumb of your hand is fit into that fossa, it belongs to the right side. If the left side thumb is fit into that fossa properly, that is a left sided fibula. And what are the things? The most important is the nerves in relation with the proximal, that is common peroneal nerve. Then they may ask you with the Henry's posterolateral approach. Then longitudinal approach to the distal fibula. What are the functions? 6% of the weight is borne through the fibula. Different muscle attachment. It can be used for the bone graft also. Only you have to remember that distal one for the fibula must be kept to maintain the ankle stability. Sometimes you have to do the vascular fibular grafting or non-vascular. In vascular, you take a blood supply from the common peroneal artery. This is the nerve which is in relation with the fibula. There is a common peroneal nerve. It comes along the posteromedial border of the long head of bicep, femoris, and then it goes downwards and winds around the neck of the fibula. It enters into the peroneus longus muscle. Then ankle joint, the commonest question would be asked on the ankle fracture, and the examiner is of old fashion. We may ask you about the Log-Husser classification, and this is another classification which currently used, the Weber's classification. Examiner may ask you named fractures around the ankle. So these are the 7 fractures: Potts fracture, Cotton's fracture. I will show the picture in the next slide. This is the Bosworth fracture. What is it? It's the fracture of the proximal aspect of the distal fibula, which is trapped posterior to the distal tibia. So like this. So that is a Bosworth fracture. Runner's fracture, that is a stress fracture of the distal fibula, 3 to 8 centimeter above the lateral malleolus, like this. That is runner's fracture. Then there's a trimalleolar fracture, which is also called as Cotton's fracture. There's a fracture of the medial malleolus, lateral malleolus, and posterior malleolus. That is a trimalleolar fracture. Mason's fracture, that is a fracture of the neck of the fibula or upper third of the fibula with diastasis of the inferior tibial floor joint. That is a Mason's fracture. Then Potts fracture basically is a bimalleolar fracture. Both the malleolar fracture here. Dependence fracture dislocation. There's a damage to the medial deltoid ligament, or maybe fracture of medial malleolus, fracture of the lateral malleolus, and fracture of the posterior malleolus with dislocation. This is a dependence fracture dislocation. If it happens to go in your ward to see the
patients before your examination. If the patient is there of any fracture or any other fracture, and if the examiner asks you, if you don't know, sometimes examiner may ask you in the examination the same question. And if you do not know, then he's likely to fail you. And this is what I did once. I asked the student who came to see the patient. There was a patient with fracture dislocation, repeated fracture dislocation. I showed that X-ray to the student, and they didn't know it. They didn't bother to go and check it. What was that fracture? In the examination, I asked the same. I showed the same X-ray, and they did not know it. So I failed with the students. So this is very important. You have to take the tips from your examiner. Then about ankle, they may ask you about syndesmotic injury. How will you make a diagnosis intraoperatively? So you have to do the pronation, external rotation, stress view under C-arm, or Cotton's test, or maybe the tap test. If the displacement is more than 5 millimeters, sorry, then you have to consider the fixation. And I'm sure you must be knowing these different steps how we fix the syndesmotic injury. Then posterior malleolar fixation, this is another interesting fracture. What are the indication? Articular surface involvement should be more than 25 to 30%. Displacement should be more than 2 millimeter. Posterior subluxation of the talus should be there. And if you want to restore the syndesmosis, then you should fix the fracture. And what are the approaches? Posterolateral approaches, which is very commonly used either in the prone or lateral position. Dr. Kakatka sir is very fond of using the lateral position. And then I usually fix it with this lateral approach of Gatler and Chasta. And there could be, if you could reduce it under the CM and anatomical reduction could be achieved, then you can fix it with the anteroposteral screw or maybe posteroanterior screw. When the talus is given, you have to describe the talus, head, neck, talus, articular surface on the lateral malleolus, lateral process, posterior process, everything you have to describe it. Please remember about the blood supply. All three arteries give us some contribution to the head, but the major blood supply comes to the perforating peroneal artery and some branch of the anterior tibial artery. They perforate the talus on the dorsal surface of the neck like this. These are the foramen which are seen. Therefore, the vessels. And there's some blood supply come from the artery of the tarsal artery also. Please remember, there are no muscle attachment to the examiner. Asks you what are the muscles are attached to the talus. Then you start thinking which muscle is attached. But there are no muscle attachment. Only few ligaments are attached to the talus. They may ask you about the fracture neck of in Hawkins, and then how do you treat it? If it is really undisplaced, you can treat it by the plaster. Most of the time it needs surgery, and fixation could be done by using the two interfragmentary lag screw or sometimes mini fragment plates. The next bone, which is calcaneum, a lot of interest is developed, especially by the foot and ankle surgery. Previously, all fractures. Main is about the fracture. So you should know the different anatomical features of the calcaneum, which are shown in this picture. The commonest question would be the calcaneal fracture. So basically, there are two types: extra-articular and intra-articular. And intra-articular fractures, they are classified by Essex Lopresti. It's a historical classification and basic classification. And basically, there are two types: joint depression and tongue type shape. But the latest classification is the coronal CT-based Sanders classification. So all fracture calcaneum should be subjected for the CT scan, 3D CT, and you find out what type of classification is that, what type of fracture is that. So depending upon, you can treat with the conservative or operative. And if you do the operative, you have to do the open reduction with the calcaneal plate or maybe Sherman plate, or maybe with the multiple character screws, or sometimes you can do the closed reduction and fix the fracture by percutaneous K-wire fixation, that is a popularly known by Essex Lopresti technique. Then they may ask on the tarsal tunnel, which is present on the medial side. There's a flexor radiculum which is attached to the tip of the medial malleolus and medial tubercle of the calcaneum. So that is a tarsal tunnel. What are the contents? Contents are the posterior tibial tendon, flexor digitorum longus tendon, posterior tibial artery, posterior tibial nerve, and flexor augustus longus tendon. Then we may ask about the sinus tarsi, which is present on the lateral side, that is space between the talus and calcaneum. And they will ask you what are the contents. The contents are adipose tissue, few ligaments attachment, and few blood vessels. Then the foot, there are total 26 bones present in the foot. The commonly asked question on the Lisfranc injury. And what is it? It's basically the torsometatarsal fracture dislocation. And the traumatic disruption between the articulation between the medial cuneiform and base of the second metatarsal. This is the Lisfranc joint, which is popularly known. Now, what are the types? It could be homolateral or isolated like this, or maybe divergent type. And the treatment is always surgery. You do the open reduction and fixation with the multiple screw, or maybe Lisfranc plate is also available. Do not fit with the K-wire because it doesn't stay. Then the last bone is the fifth metatarsal. Commonly asked question on the Jones fracture. So what is the Jones fracture? So Sir Robert Jones himself sustained this fracture while dancing with his wife in 1982. And Sir Robert Jones, he was trained, and also he was a nephew of Sir H.O. Thomas. So these are the three types of fracture of the proximal part of the fifth metatarsal. This is the Jones fracture. This is the evergent type of fracture, and this is the this is the stress fracture. This is the Jones fracture, and this is the evergent type of fracture. So how do you treat the fracture? By conservative methods. That means you have to give a plaster cast, below plaster cast in full dorsiflexion and eversion for at least period of 6 weeks. Or if you want to do the fixation, you can use the malleolar screw. That is the best way to fix it. Thank you, my students. I tried to cover all different types of bones, microscopy, as well as the specimens, histopathology, which is available. I do not know where your exam is going to be, and the specimens or bones or slides will be kept, which are available in that hospital. So best of luck for you. I hope all of you should pass. Thank you.
Thank you.
Didn't get you, sir.
No, he is asking whether there
is there both are same or the different, sir? Right? Radial groove in the humerus and spiral groove in the humerus.
They are same. They are same.
Okay.
both are same.
Both
Sir.
are same. Yes. Yes.
Okay.
Yes. Yes.
Both, yeah.
No questions from students.
I'm very happy that Dr. Kakatka sir came today. Last time he was not there. He missed my class.
No. I was there in your last class also, Yashwant.
No. You left in between because of some emergency case.
But I was there for some time.
Yes.